Hello, NephU Community, and welcome to today's presentation titled Hypertension in Autosomal Dominant Polycystic Kidney Disease in the General Population. My name is Dr. JessicaKanai.
And I'm Dr. Hadgu.
We are Nephrology Medical Science Liaisons at Otsuka Pharmaceutical Development and Commercialization.
We'll be serving as your co-moderators for today's program, and we have Dr. Biruh Workeneh with us today.
So our objectives today are to describe the pathophysiology of autosomal dominant polycystic kidney disease and hypertension. We will also compare and contrast the pathophysiology of hypertension in the general population, abbreviated GP, so you'll see that later in our slides, and ADPKD and CKD, chronic kidney disease. We will also discuss unique risk factors and complications of ADPKD. And lastly, we will discuss hypertension management in the general population and in patients with ADPKD and chronic kidney disease. So hypertension can be the first complication of ADPKD. In fact, in 30% of patients, it's the presenting symptom, especially upon review of the patient's chart. And so hypertension affects 20% of ADPKD patients who are less than 20 years old. So as you can imagine, it presents early, especially in patients with PKD1 mutations. 60% of patients with ADPKD of all ages have hypertension prior to the decline in kidney function. So hypertensive ADPKD patients with preserved kidney function, even with preserved kidney function, have increased total kidney volume, or TKV, increased proteinuria, and decreased renal blood flow.
Dr. Workeneh, out of the patients that you treat, what % would you say of your ADPKD patients have hypertension?
I would say the vast majority. In my experience, I've treated only adult patients. So certainly I haven't had a lot of pediatric experience, but studies show that hypertension is often the presenting symptom or the presenting sign that ADPKD exists in a patient. So ADPKD presents as a complication in 30% of patients as the initial presenting sign. It affects patients who are less than 20 years old 20% of the time. And the majority of patients with ADPKD of all ages have hypertension up to 60%, greater than 60%, and have hypertension prior to the decline in GFR. Now, patients with PKD1 mutations have hypertension earlier and more aggressively than patients with other mutations. Hypertensive ADPKD patients with preserved kidney functions also have or present with increased total kidney volume, or TKV. They have more proteinuria. It's also associated with decreased renal blood flow. So this is a complicated slide, but it shows the pathophysiology of hypertension in ADPKD. Now, we're used to thinking of PKD as a kidney disease, but it is very much a cardiovascular disease. So as this audience knows, the PKD genes encode polycystin 1 and 2. And when there's a defect in polycystin 1 or 2, then there's a cyst formation that forms in the kidney. So I'm taking you down the right side of the figure here. So there's cyst formation, and with expansion of these cysts, there's decreased blood flow in some parts of the kidney, and kidney ischemia occurs. When that happens, then there's induces angiotensin II. Angiotensin II does a number of things, and you can see that in the next to last row on the figure. It induces aldosterone, and aldosterone acts to increase sodium retention. Angiotensin II also increases vascular resistance and raising blood pressure. It results in fibrotic changes in the kidney, which in turn causes progression of CKD. And also it increases proliferation of cysts. and then that feeds back to the top of the right side of the figure again. And so this is, for years, for decades, have been the central dogma of why patients with hypertension have why patients with ADPKD develop hypertension. But in fact, we're learning that polycystin is also affected in the in vasculature. That polycystins are expressed in the endothelium, and therefore there are other abnormalities that can occur independent of what's happening in the kidney. And so we see patients, in addition to hypertension, develop LVH, that's left ventricular hypertrophy. We see valvulopathies. Patients can develop intracranial aneurysms, which we'll talk more about during this presentation, and pericardial disease. So it's very much a cardiovascular disease. Polycystin 1 and 2 are expressed in endothelial cells, and the endothelial dysfunction can result in decreased nitric oxide production. Now we're onto the left side of this figure. There's decreased nitric oxide production. That means, when we test patients with PKD for flow-mediated dilation, they don't react as well. They don't dilate their vessels, and there's more inflammation in these vessels, and that in turn contributes to the hypertension that we see. And so the pathophysiology of hypertension and ADPKD is much more complicated than we initially thought. Much of what we thought about it is true, but there's layers to the story that we're continuing to discover.
Wow, you did a great job summarizing this beautifully. So this is focusing pretty much on the pathophysiology of hypertension and ADPKD. And I wonder if there are multiple mechanisms that could be present, especially when you're thinking about other patients with other comorbidities such as CKD.
That's a great question. Certainly in any patient that you see, you shouldn't have blinders on and not consider other possible diagnoses, especially if patients exhibit a resistant hypertension, then other diagnoses should be considered.